We're now on to ECT. ECT can be administered under the Adults with Incapacity Act if somebody lacks capacity and is not subject to detention under the Mental Health Act. So for the majority of ECT indications for mental illness, a Section 47 alone is not adequate authority. As we talked about before, that's a safeguarded treatment, and it requires the Section 48 authorisation certificate. So the doctor would still complete a Section 47, but would contact the Commission and ask for a GMP visit. The GMP would make the determination about whether or not to authorise the ECT. In an emergency situation, if there's a delay in getting a GMP out, then ECT can be given if it's needed for the preservation of life or the prevention of serious deterioration. And that's a clinical decision for the treating physician, but they can give it in an emergency before they have the GMP authority. However, if they do that, the regs are very clear. They must notify the Commission within 7 days of the emergency treatment. Now, this is something that very rarely happens. And if it does happen, we would expect to be notified on the day the treatment is given, for the simple reason that we could then ensure that the second opinion doctor is aware of how urgent the situation is, and we could get the Section 48 safeguards in place as quickly as possible. When it comes to treatment for mental disorder, the 2003 Mental Health Act always trumps the AWI Act. So if somebody is subject to detention under the Mental Health Act, then their ECT would be administered under the provision of Part 16 of Mental Health Act rather than AWI. Just one proviso, that the Act does say that where ECT is used as a treatment for physical disorder, not mental disorder, it can be given under a Section 47 certificate alone. But I had to say, I couldn't think of any condition where ECT would be used purely for a physical disorder. Part 6 of the AWI Act is the part that covers intervention orders and guardianships. Both of those can be used to authorise a healthcare intervention. An intervention order would cover a single intervention or a linked series of interventions, for instance, a single operation or a course of treatment. And that would be used where Part 5 cannot be used. And the most common reason for that is because force is not immediately necessary, but is likely to be foreseeably necessary, and perhaps repeatedly, for the course of treatment. So if it's predictable that it's likely to use force, that it's necessary to use force, then in that case, you would go to a sheriff, apply for an intervention order, and he would grant the specific power to use reasonable and proportionate force, including restraint. Now, a welfare guardianship would be more suited to a foreseeable series of healthcare interventions. So if it's not a one-off, it would be more appropriate to get guardianship. Chronic illness, where somebody regularly is resistive to treatment. Something like where somebody gets very distressed during physical health care, such as washing or toileting, and requires or can sometimes require restraint. If that's predictable, then you would apply for a welfare guardianship with powers to authorise the medical treatment. And if force is needed to deliver that treatment, you would be wanting specific powers to authorise reasonable force. And obviously that would need to be assessed, and you would need to provide evidence that that was necessary, but you would need specific powers. If the person's going to recover capacity, if that's likely, it would be more appropriate to use an intervention order, but for a lot of cases, a welfare guardianship is much more appropriate. If an adult doesn't comply with the wishes of the guardian, if they refuse to comply, or if they won't comply with what's in the intervention order, then a sheriff can issue an order under Section 70, which compels the individual to comply. However, Section 70, when you read it, appears more to have been designed to allow taking the adult to a place of residence rather to enable the provision of medical treatment, but it can be used for that. One thing that a welfare guardian can't do is place an adult in hospital for treatment of mental disorder against their will. That can only be done with detention under the 2003 Act. So that's not a power that a guardian has. The Act, and I suppose also I should say that the 2003 Act trumps guardianship or power of attorney when it comes to providing treatment for mental disorder, but I know Leslie will cover that in her presentation. The Act also says that once a guardianship application is underway, then a Section 47 certificate cannot be used to authorise treatment. So if I'm applying for guardianship for my gran and I'm going to have powers to consent, once that application is with the court, a Section 47 should not be used to authorise treatment. In that situation, the treatment could only be given if it's necessary to preserve life or prevent serious deterioration. Now, that was a discussion of I think it was a West Lothian case, where the sheriff considered that because the application was underway, Section 47 couldn't be used, and they had to get an interim guardianship order with powers to consent to ensure that treatment could be legally provided. The Commission thinks that needs to be clarified further, because for treatments that are not necessary to preserve life, for non-urgent treatment, but necessary treatment, to have to get an interim guardianship order while you're waiting for the full order could cause delays. And also, unless there's any dispute between the proposed guardian, the applicant, and the treating physicians, it seems to be disproportionate. But that's not a legal view, that's our view, and any clinician in that situation would have to take legal advice on that one.